Hello, welcome to this menopause webinar brought to you by the Active Wellbeing Society and Lotus Menopause Care. Just to give you a bit of a background, Active Wellbeing Society, or TAWS, as you'll hear us referred to as, is a community benefit society based in Birmingham in the UK, focused on serving the least served members of the community to lead healthy, happy and connected lives, both here in Birmingham and beyond. My name is Charlie, and I'm the Virtual Wellbeing Project Lead for TAWS, with my aim being to bring people, often the most isolated, together in online spaces like this, to be active, social, express themselves, learn, connect, enact change, create, and more from wherever they are in the UK, which brings us to today. This webinar was developed based on the voices kindly offered by the TAWS community, who told us what was important to them about menopause information and what's been missing. We connected with Dr. Jacqueline Bowden, who you can see on screen now, an expert in this field who's been helpful, caring and responsive in working together on this presentation today. We've tried to make this presentation and the supporting resources that come with it more representative of a variety of experiences of menopause. And while we know we can't hit the mark for absolutely everyone, we hope that this format is more relatable for folks. There might be language new to you or different to what's usually used in menopause resources here and in the documents as well. This is to ensure fewer people are erased from the menopause journey, and we ask that you respect this in your engagement in chat as well. Alongside today's presentation, there are two documents you can download from the Files tab at the top of this screen, and it'll also be in the chat later on as well. And that's if you're watching live. If you're joining us in the future and you're watching back on YouTube, these will be available on the Menopause Resources landing page on our website. And the link for that will be in the description below, alongside other information about the Active Wellbeing Society and the community work that we do. One of the documents is a version of this presentation, and the other contains a wealth of links to organisations, blogs, lived experiences, articles, and other helpful tools to help you on your journey, both of which are e-reader friendly. I'm going to start with a bit of housekeeping, just so you know what to expect from today. We're going to go at a fair pace, just because of the amount that Dr. Bowden has to share with you. And you'll find there's quite a lot of information on the slides. But if this is a lot to take in, or you struggle to read and listen at the same time, like I do, don't worry. All the information from the slides is in the supporting resources. So you can read this back at your own pace, or watch back the webinar and read the document at the same time. It's completely fine. You do this however suits you. Like I said, the chat box is open, so say hi, let us know who you are and where you're joining us from. There is time for a brief Q&A at the end as well, where we'll be covering some pre-submitted questions, but you can also submit questions in the Q&A. We'll pick a few of those based on time and themes, but sadly, we don't have capacity to get around absolutely everything. And as ever online, we encourage you to consider your online safety. Remember not to share too much of yourself. Keep things vague and don't disclose any personal or identifying details. Do engage in that chat, really do encourage you to, but just remember to kind of teeter on those kind of boundaries. Number one is to keep things respectful. We are different people with different journeys, particularly in menopause, and it's our difference that we're here to embrace, celebrate and learn from. So please respect each other and make space for all that learning. And with that, I will make some space for Jacqueline to step up. She's a GP who has made menopause her specialism, now running Lotus Menopause Care, with the emphasis really being on care. She is a well-respected speaker who will definitely hate that I've said that about her, and is an influential voice in the menopause field. We're really grateful that she shared her time and energy with us today and on the build up to this and helping create all of these this information. And she's going to share some knowledge with you to help you on your own menopause journey, to kind of tool you up in the conversations that you have with your medical professionals and with other people who may be supporting you or your members of family, that kind of thing. So, Jacqueline, it's over to you.
Wow. Thank you, Charlie. Yes, so hi, I'm Jacqueline. I spent the first chunk of my life being a GP. For 26 years, I was a GP partner. And since about 2018, 2019, I've been working increasingly in the field of menopause care, which I absolutely love. I still do some general practice just to keep those skills in, but I'm here as a menopause advisor, really. So the first slide is here. It's just a little bit about me. I've got now a CQC registered virtual service, so I see people primarily via video consultations, although I do have a couple of sites, one in Stafford and one in Solihull, where I can see face to face if that's preferred. But perhaps if we just go to the next slide, and I'll start talking to you about what you've come here to listen to. Okay, so what is the menopause? So I'm going to talk a little bit about this, because I think it's always dangerous to assume that everybody knows. I certainly know when I was growing up, I vaguely knew that my mum got hot and that perhaps periods were changing, and that was absolutely all. She didn't share anything with me at all. So again, in medical school, I didn't get taught about it at all. And I know in the 1980s, that was probably quite a long time ago now, but still that situation is starting to improve, but not so much. So the menopause actually is a little word that encompasses an awful lot. The menopause, actually, our menopause is one day in our lives, which is 12 months after our last normal menstrual period. But actually, the term as we now use it, encompasses the perimenopause, the menopause, and the postmenopause. So the perimenopause is the period of time during which our ovaries are not working as well as they used to earlier on in our lives. So they function and they release an egg some months, other months they do not. So as a result of that, our hormones are a bit like the Syrian Empire. So our bodies just don't know where they're coming or going. And that period of time can last anything from 3 to 7 years before our scheduled date of last period. The average age for last period in the United Kingdom and in most of the Western world is 51. The normal range is 45 to 55. So if you think about that, the perimenopause, it is normal to be having perimenopausal symptoms 7 years before the age of 45. So that starts in our late 30s. So when we're born, we have pretty much all of the follicles and eggs that we're ever going to have. They develop when we're fetuses, and they're slowly released. So we've got a biological clock going there. Our menopause is predetermined before we're born. That can be altered by some situations. It can be altered if we have medication that causes problems to our ovaries. Largely that is chemotherapeutic treatments for cancer, or if we have surgery that removes our ovaries, and typically that will be for people who've had problems with a lot of cysts and pain, who may have had endometriosis that is deposited throughout their pelvis, or because they've developed cysts that there have been concerns about. So the menopause will happen to everybody who is born with ovaries. Now that is really important, that little phrase, everyone born with ovaries, because not everybody who was born with ovaries identifies now as being female. So I'm going to use the term female and woman, but I mean that to be inclusive, and I understand that people would have different gender and preferences or identities within that. Anything before the age of 45 is considered to be an early menopause, and anything before the age of 40 is considered to be premature ovarian insufficiency, or POI. The picture on the right is something that's been produced by the Menopause Support organisation and the Make Menopause Matter campaign, and it gives an idea of just a very few of the symptoms that are possible. So we're looking at things that people might not have considered before. So it's not just hot flushes and wonky periods. It can be losing your words. It can be not being able to maintain focus or concentration. It can be dry eyes, a dry mouth, dry skin. It can be anxiety. It can be social withdrawal. It can be having very
Yeah, so I think Jacqueline may be having some connection issues at her end. So I'm just going to give her a moment to maybe reset her connection and rejoin us. So sorry about the delay on this. We do sometimes have these issues at virtual events. It is the nature of the lovely virtual beast that we are dealing with. So please do just bear with us, and we'll be back with you. Here we go. She's had to go out and come back in again. So just 2 moments. We'll get her back up on your screens with you. There we go. She's back. Sorry about that, everyone.
I don't know what happened. It just suddenly all went blank. You see, I'm a menopause doctor. I'm not an IT person.
That's absolutely fine. We do have these problems sometimes. That's not a problem at all. We just caught you at the end talking about menopause at different stages and the different types of symptoms that you can be having that may be less spoken about. That was all.
Okay, so I think I sort of got to perhaps the anxiousness type symptoms. Lack of sex drive can happen as well. Problems with digestion, weight gain, sluggishness. I think the psychological symptoms are ones that people find most troubling, as well as the achiness and also the brain fog, the not finding words, not concentrating at work because of the impact it has at work. So a huge array of symptoms. So could I have the next slide, please, Charlie? Okay, so as I've said, the average age of menopause in the UK at the moment is around 51. And that's actually come down in around the 1900s. It used to be 57 years of age. And when you think about it, life expectancy in the 1900s was about 59. So we're only spending about 3% of our lives without any estrogen. Nowadays, we spend around much closer to 40% of our life without estrogen. So it becomes a much bigger issue for a much bigger proportion of our lives. So I think the old adage that it's just something we just have to grin and, you know, bite down on a stick, grin and bear it. You might manage that for 3% of your life, but to be expected to do it for up to 40%, I think is a bit grim. Which is why, particularly now, I think we need to know more about it, and we need to know what our options are, whether those be lifestyle, hormonal, non-hormonal. Next slide, please, Charlie. This is my sort of quasi-funny slide, really, and I think people, menopausal women, we've been the butt of jokes for years, haven't we? But I think if it helps us to cope with it, a little bit of humour, then it's not a bad thing, as long as it's not directed at us. So we've got the 7 stages of the menopause here. We've got itchy, bitchy, sweaty, sleepy, bloated, forgetful, and psycho. And certainly I can associate with absolutely all of those, actually. So why does estrogen cause this, or a lack of estrogen cause this huge change and all of these big, really difficult things to navigate? It's because we've got estrogen receptors on every single cell in our body. And estrogen is the hormone that gives us energy. It causes everything to grow. It looks at neurons, brain tissue, bones, tendons, all of our other metabolic systems. It's the driver in all of those to yes, generally to be the best that they can. So the long-term effects of the lack of it are more than just having some hot flushes. We're more likely to develop diabetes and insulin resistance, so that's type 2 diabetes, if we have an early menopause. So we know that replacing estrogen helps our body to recognize and deal with glucose properly. So we're less likely to get a metabolic syndrome, insulin resistance, and diabetes. We know absolutely that without estrogen, our bones do not make new bone, which we really need. So without estrogen replacement, 50% of us will develop osteoporosis, which is significant thinning of the bones, which means of those 50%, 30% of those people will go on to get something called a fragility fracture, which is a break of a bone because it's not strong enough. These will typically happen in the spine or in the long bone of the legs at the hip joint. And having one of these fractures is then associated with a 25% mortality rate in the following year, because having a hip mended means that you've got to be in bed, you might get pneumonia, complications of surgery. So this is something we want to avoid. Osteoporosis in the spine, the fractures, the breaks then that happen in the spine, they're crushed down, they can be very painful, so we don't want that. We know that if we replace estrogen, we are going to reduce our risk of developing cardiovascular disease. Now, cardiovascular disease is one of the biggest causes of death in the Western world. And by cardiovascular disease, I don't only mean heart disease and angina, I also mean strokes, because strokes happen because of abnormalities of our vascular system. So we know that people who choose to replace their estrogen will live longer and healthier and will have less cardiovascular events than people who choose not to replace. Having said that, I would like to add the addendum here that it is possible to be really diligent about lifestyle changes, about exercising appropriately, eating an appropriate diet, stopping the bad habits that we know are not good for cardiovascular disease, such as smoking and excess alcohol. And there are other ways of making significant differences that if we're wise, we do, as well as replacing hormones. But for those of us who choose not or cannot take hormones, all is not lost. There is a lot of lifestyle interventions that can be made as well. We know that, as I've said already, estrogen is involved in the health of brain tissue and nerve cells. So all nervous tissue can regenerate. We know that when we lose our estrogen levels, the activity and the quality of what's going on in our brain starts to deteriorate. So we know that replacing estrogen helps with the general health of our brain. What we cannot say is that replacing hormones decreases our risk of getting dementia. We do not have medical evidence for this. We do have evidence that replacing estrogen will reduce the likelihood of having the word losing and brain fog. That is a short-term issue that is often associated with the perimenopause and menopause, and we know that replacing estrogen will stop that. But whether replacing estrogen stops us from developing a full-blown dementia later on, the jury is still out on that. We know that when we're lacking in estrogen, we are subject to mood disorders. Some of you may have had experience with menstrual dysphoric disorders, so disorders that happen before we have a period or cyclically with our menstrual cycle. That makes us much more prone to postnatal depression and also to mood disorders during the menopausal transition. Okay, next slide, please. Okay, I think we might have jumped 2 there, possibly. Are we okay, Charlie? Okay, well, that's fine. So anyway, I mean, I think the menopause, it's actually a really good opportunity because it stops us in our tracks very often, and it's a chance for us to look at life and our health generally, because lots of things are changing at the same time. So that average age of menopause, which is 45 to 55, let's just think for a minute about what else might be going on for us. So we're getting a bit older. Our body's suddenly telling us that we're unlikely to be having any more children. So we're moving to a different phase of our life. If we have had children, it is likely that those children are either doing very stressful exams, they're moving away to university or jobs, or starting their own families. So our role in life changes if we've chosen to have a family. Even whether we've chosen to have a family or not, if we're lucky enough to still have parents, they are likely to be needing our help and our support in a way that I think they didn't have perhaps a generation ago, because life expectancy has increased, because healthcare and public health and knowledge of nutrition is so much better. So we find ourselves not only having all of these menopausal symptoms, but the makeup of our life is changing. We'd perhaps thought that when our children left home that this was going to be our time, and we find that it's not quite as simple as that, because we've still got parents who are starting to need us more. We've perhaps reached a level of our career that we've always wanted to reach. We're no longer constrained by so many responsibilities and timetables at home. And then all of a sudden, we find that we've got brain fog. Perhaps we're in the perimenopause and we're having problems with flooding and leaking. We don't know when we're going to have a period. So we stand up in a room full of people to do a presentation or at a meeting, and you have that moment where you're sitting down and you've already come in your black trousers just in case, and you think, oh my goodness, what's happening? Then you get a whoosh of a hot flush and your brain goes all wonky. So is it any wonder that we then have all of these other things? So as well as looking at just replacing our hormones, this is a brilliant opportunity to look at everything else. So we can look at our physical health. As part of that, we look at how much we're moving and exercising. So this is not to become a complete fitness freak. We do not need to be doing HIIT classes 4 times a day and running a half marathon twice a week, anything like that. What we need to be doing is moving and looking at how we move and what sort of movement we can find that fits in with our life and makes us feel good. So it might be going for a walk with a friend. It might be doing a yoga class at home. It might be kayaking down the River Severn at some point, or on the River Wye, wherever. So it's about finding an exercise that works. We know that we need to be moving for about an hour and a half per week in aerobic exercise, or 2.5 hours of increasing our heart rate, then about another hour to an hour and a half of muscle building exercise. We can look at how we're eating. So we're learning much more about what is good for nutrition. And I'm really unkeen on the word dieting. I like nutrition, eating well. And I haven't got time to go into this hugely, but what I will say, if you're going to make any dietary change, is the one that has an evidence base that will help us with our general health, with our gut biome, with our cognitive reserve that we're trying to build up. Avoiding cardiovascular disease and diabetes is the good old Mediterranean diet, but it needs to only include extra virgin olive oil as well as our seeds and nuts. So we can start looking at that. And if we don't, we really are missing a very big trick. We need to look at our lifestyle generally and any other health conditions that we have. And by that, I mean smoking, alcohol. I think many people who suddenly find themselves getting very stressed at work, having brain fog, just feeling dreadful, not wanting to go out. It's very tempting to slip into having a glass of wine while we're cooking a meal and then another one later. And this all adds in to issues. We need to be looking at social and family issues, as I've mentioned, and also past life events. If we are able to start working through any of those that may happen, it will reap benefits not only for our emotional life, but for our physical life and our cognitive health, so our cognitive reserve as well. It's a time where we can start to access new support, learn some new skills. There's a growing number of groups around. There's the Blue Tits, the wild swimming. There's organisations for people to get out there, to go cycling, to go walking, things that don't have to be expensive at all. And then we've got the good old HRT, which is kind of what I suppose you're expecting to hear from me, because I am a doctor after all. So we also need to think about our hormone health. So there's different ways that we can do that. We can use hormone replacement therapy, which is estrogen and progesterone and testosterone. We can look at local estrogen therapy, which is not considered to be HRT because it's only delivered locally and is not really absorbed into the general system. So that's used for vaginal and vulval problems. The term now is no longer vaginal atrophy, it's genitourinary syndrome of the menopause, because it's effects of the vulval tissue. And I'm going to take the opportunity of showing my new visual aid, which is a golden vulva with a clitoris on the back. So anything that affects this area, the vulval area, and then the bladder, which is at the top of this tiny little tube that you can see there, hopefully, that is also affected by estrogen, and we can help by using topical estrogens on that. I'm conscious that there may be people here in the audience who, for one reason or another, hormonal options are not for them. It might be a personal choice. It might be because of past medical history or treatments that they have had, in which case we can also look at non-hormonal options for symptom control and long-term health. And I can include this in a resource pack, but there's a particularly good book for that, which I don't know if you can see. Actually, it's called Natural Menopause and it's written by Anne Henderson. So that will cover non-hormonal options for you. Next slide, please. So I'll talk now about HRT and the different sorts. So when we're thinking about HRT, the main hormone that we're wanting to replace is estrogen, because that's the one that has the most effects for us throughout our body, from our brain down to our toes. And traditionally that used to be given in tablet form, and the estrogen was derived from either laboratories or from concentrated mare's urine. these are no longer really in mainstream use anymore. And what we do now is we get the estrogen or the estradiol that we are needing from plant-based sources, which are largely yams and soy. The estradiol is then placed into a formulation that can be absorbed through the skin. So why is it better to have it through the skin? If you have estrogen as a tablet, it goes mouth, stomach. From stomach, it is absorbed to your liver. Whilst passing through the liver, it wreaks havoc with your clotting mechanism, and it can cause an increased thrombosis risk, which means that anyone who is at a high risk of cardiovascular disease, anyone that has migraine, they should absolutely not have oral estrogen, because the increased thrombosis risk can increase a stroke risk. Likewise, anyone that has got a previous history of thrombosis or is known to carry a genetic disorder that means that they're more likely to have a thrombosis. Some people do still choose to use tablets. Tablets are easy. We're used to doing it. Popping one tablet a day is often easier for a busy person. So if someone's of low risk, I wouldn't not give them a tablet, but my preference is to try through the skin first. So how do we get it through the skin? We've got 3 main ways of doing it. So I'm now hoping I've got everything to hand. A gel we have, the most commonly used one is called Estrogel. That comes in a canister and it looks like that. So it's a clear gel, we smooth it over the skin and it dries in 5 to 10 minutes. Other gels, lotions and creams can be put on it as long as you leave it an hour for it to dry. We dose adjust with that. There's also another gel that comes, it's called Sandrina, comes in a little foil packet. Some people, it's amazing how different skin absorbs differently. So some people will absorb this better than they will absorb that. Other people prefer the packaging. If it's someone that travels a lot, these are easy to carry. So everything is very individualized. We also have estrogen patches. So I've got a couple of those to show you. 2 main brands that I use because they're well absorbed and well tolerated with very few allergy reactions. So this little one is called Estradot and the bigger one is called Everel. Both of them, you take the backing off, if I can get it off, and you stick this to skin usually below the waist, bottom, upper thigh, easily hideable. These are really popular and they've got, the problem with these is supply at the moment. It's very intermittent. These are a little bit more available. Both of them slow release estrogen over about 72 hours. So they're changed twice weekly. And the boxes are really sweet because they come with an idiot-proof pack. So you've got the day you put the first one on and then the day you need to change the second one. A few people do have problems with them coming off. In my experience of seeing people, it tends to be those who are, I had one lady who was a rower, so she was up at 5 o'clock every morning. Another lady who was a keen triathlete, so she was getting wetsuits on and off all the while. I've recently had a message from a friend who lives in Spain where they've been having really immensely hot weather and her patches were sliding off because she was so hot. But generally speaking, patches stay where they're put and you just take them off and change them twice a week. The other product that is available is a spray called Lenzetto. And when it first came out, we all thought, whoopee, this looks amazing because it's a liquid. You spray it onto your upper arm and it's dry in seconds, which is great, isn't it? But a few problems. One, that is an awful lot of plastic. That only contains 56 doses. The licensed dose for this, which is the level that has gained authority from the Medicines Advisory Panel in the UK, is up to 3 sprays a day. In my experience, and that of very many of my colleagues, 3 doses of this is often not enough to control symptoms. So people are having to use 5 to 6, which means you're getting through a huge number of these in a month, which is not great for the planet. It's costly if you're buying it privately, and it's costly for the NHS. So it's something I say for people who are likely to need lower doses and who have tried everything else and it just doesn't work. So those are your estrogen choices. Then, of course, there are still the tablets. So what's the other hormones that we look at? Progesterone is another hormone that goes up and down and is produced during our menstrual cycle. And we need when we're taking HRT, because without it, estrogen on its own, it's the giver of life, it's the grower, it's the nurturer, it's the hormone that goes up when we're pregnant to make that lovely cushion so that the fertilized egg can grow. And if we just let it run riot, then those cells will keep growing, and a proportion of them, a percentage, have the capability to become cancerous, which obviously we don't want. So we need our friend progesterone to counteract that. So we give it, so we stop that endometrium, that lining of the womb, from swelling up in a way that will A, cause bleeding, and B, potentially be dangerous. So there's several different ways that we can have progesterone. Traditionally, the older products were using manufactured progestogens, which were largely in tablet form. Nowadays, we are able to extract a progesterone component from yams and soy, which is chemically identical to the one that we produce in our body. And for that reason, it's called body identical progesterone. And this progesterone is made into a form that we can absorb, and it's encapsulated in a gelatin capsule, and they look like this. It is called Utrogestan. The advantage of this body identical progesterone is that it is not associated with an increased risk of blood clot, which some of the older progesterones were. And also, when we're thinking about breast cancer risk, which we know is increased a very small amount after 5 years of HRT use, and I'll come on to that later because there's many ways that we can counteract that and things that are worse for breast cancer risk. But the older progesterones that were synthetic, so were manufactured, are much more stimulatory to breast tissue. And it's the combination of estrogen and progesterone, not estrogen alone and not progesterone alone, that causes the breast cancer risk. So women who are hysterectomized, who don't have a womb, obviously don't need progesterone unless, well, there is one circumstance for endometriosis sufferers, but most women who've had hysterectomy do not require progesterone. Those women carry a lower breast cancer risk because they're only having estrogen. Likewise, if we were only to give someone progesterone, it would not increase their breast cancer risk. You put the two together, it does. But this is the safest progesterone we have. There has been shown to be a small increased risk of breast cancer at 5 years when we combine it with this, but it's lower than with the old-fashioned progesterone. So this is our safest progesterone, which is fab. But, and then why is there always a but? But unfortunately, it is the least good at controlling bleeding. So some people are fine on one of these capsules, some people need two, some people find that their bleeding is controlled if they use it via the vaginal route, which is off-label, but it can be used that way. And some people even need up to three. That can be problematic because this progesterone is sedating and it's calming, because progesterone is the calmer downer of everything. So again, you need someone that can advise you about how we manage all of these things, because, you know, some sedation and some calming is really useful, but too much is not. So that is our preferred progesterone. There are still synthetic progesterones available, and they're getting much better at making the synthetic ones. So there are some newer synthetic progesterones that are much safer with regard to thrombosis risk and breast stimulation than the older ones contained in some of the tablets. There is only one through the skin progesterone, and that is in a patch called Everel. I've shown you earlier Everel that's just got estrogen in it. Well, they also make a patch that's got progesterone in it as well, and that's either Everel Sequi or Everel Conti, depending on where you are in your journey. Which brings me on to how you take your progesterone. If you start your HRT and you have still been having periods, however irregularly, then we put you on a sequential, what we call a sequential regime, which is one that mimics your natural body cycle. Because what we don't want to do is to go into battle with your hormones. And if I tried to put you on a continuous regime and you were bleeding through it because you'd still got intermittent ovarian function, I don't know if you're bleeding because there's a problem or because it's your ovaries. So we take a much more sensible, I think, option, and we use sequential HRT. So you would have your progesterone for 2 weeks on and 2 weeks off, so you would still have a bleed. If, however, you're coming to HRT and you haven't had a bleed for, traditionally we used to say no bleeds for 12 months, I think more of us are more prepared to add in at a combined regime much sooner than that. So perhaps if you haven't had a period for 6 months, we would say, look, we'll try on a continuous regime, which is intended to be bleed free, and you take your progesterone every night or every day. So what are the other options? The Mirena coil is a brilliant option, and I'm just looking around me because I think I've managed to leave it downstairs, but I've got a little one that's similar that I can show you. The Mirena coil is a progesterone containing coil. So I can show you this picture. Down the T-shaped stem of this coil is wrapped some progesterone, which is slow released. And it's slow released if it's used for contraception over 6 to 7 years. When we use it for HRT, we can only use it for 5 years. This was originally developed as a contraceptive. Then it was discovered that about 80% of women after a year of having one fitted were bleed free. So it then meant that we were using it as a treatment for heavy periods for people who got fibroids and so on, which massively reduced the hysterectomy rates. And then it was obviously started to be used to protect the lining of the womb during menopause care. So for HRT, it's a really good way of doing it if you need contraception as well. And it's also really good for people who are really struggling with unpredictable bleeding and flooding, and that is going to help. So they're great. Obviously, they've got to be fitted, and that's a whole another topic, but it's kind of like a smear with a bit extra on for most people. So there's that way. And then we've still got the synthetic progesterones, which we do use. And if any of you listening are using HRT now, you may be aware that there have been supply issues with Utrogestan, basically because we're prescribing more than the factories that are already in existence can produce. So you may have been changed onto something like Provera, which is a synthetic progesterone isn't quite as safe, but is perfectly fine to use for a small period of time till we can get our Utrogestan back in stock. Testosterone is the third hormone. It's not one that is routinely used for hormone replacement therapy, but it's one that can be very useful indeed. Testosterone is produced both by our ovaries and by our adrenal glands. And what does testosterone do for us? Well, there's not a great deal of research on this, so we know a little bit, and a lot of the knowledge that we have is what we call anecdotal, so it's not backed up by science. And we've only last week had the, I think, really awful news that there was a proposed trial looking at the effects, the benefits of testosterone for women other than improving their libido, and the funding for that trial has not been granted, so it's not going to go ahead, which I think is hugely disappointing. At the moment, we have BMS, so British Menopause Society, and NICE guidance that states that we can introduce testosterone for those women in whom estrogen replacement has not improved their sex drive or their ability to have an orgasm either with a partner or on their own. So that's the recognised and guidance reason for doing it, and the evidence-based reason for doing it. However, I've seen many women who have had testosterone replacement, and they tell me that they feel much more motivated, their brain fog improves, they are more energized, more on life, more able to spin those plates. But again, that's not a proven use Yes, I've just seen a quick question. If you've had your adrenal glands removed, yes, your testosterone would be reduced, and it would have fairly big impact on all of your hormones because that's a powerhouse of hormone production. So testosterone replacement products. This is a bit of a tricky one because there is not a licensed product for use in women in the United Kingdom, or indeed in most places in the world. The only country that has got a licensed product is Australia. Now, this doesn't mean that there aren't products available that contain testosterone that can be used in women. There are plenty of them. It's just that they haven't gone through the necessary hoops to get a license to be used in women. It is drug companies that spend the money to get the data, to get the licenses. It's expensive, so they won't do it if they don't think they can make a good profit out of it. So they haven't done it. The product that is licensed in Australia is called Androfem. It comes in a pink and white tube, so we know it's intended for people with ovaries because obviously they all identify as pink. It's a cream, not a gel. So it looks like that. It's measured out using a syringe. So you have to put a syringe in the bottom, measure out 0.5 ml, and then apply that, which is great. And some people love to have that. It can be prescribed by private doctors. It can be prescribed by your GP, but only privately. So you will never get it on an NHS prescription. To buy it privately, you're looking at about £400 a year for that. Then there are a myriad of testosterone products designed for the people who are in possession of male hormones. So they come in pump dispensers and they come in sachets and tubes. They contain exactly the same testosterone chemical that is in the cream. I like to use the one that comes in a tube or a sachet because it's easier to manage. We use it as a daily application. Some of these tubes, such as Tostran, they're advised to be used several days of the week, depending on your dosage regime. And to my mind, I prefer to have a nice steady level so we know where we are. So we use the little sachets. A person with a male person would be using a complete one of these a day. We make it last 10 days. We need 1/10 of the dose. So it's what we call off-label. So it's using a licensed drug in a non-licensed way or for a non-licensed group. So the drug company won't take responsibility. It is perfectly safe. Because we have so little data, we're very careful about monitoring. So we always check a blood test before we start testosterone. We check a blood test sort of anywhere between 6 and 12 weeks after the testosterone is commenced. We make sure that you're in a reasonable physiological range for a person with ovaries. We also cross-check that with symptom control, because if someone's got great levels but they're not noticing any benefit after 6 months, we wouldn't continue it. But if they are noticing benefit, then we would continue. And then we continue to monitor at least every 12 months. Sometimes 6 monthly for the first couple of years, but then every 12 months, and keep an eye on that. It's easy to use. Very few people I've ever come across who've had significant side effects, but then I'm extremely cautious about how I start it and how much I monitor. Okay, none of the testosterone products are available on the NHS prepayment certificate for HRT, by the way. Next slide, please, Charlie. Okay, this is just my little bit, really, because I think a big part of what we need to do here is we need to be opening the narrative, which is what we're trying to do in this talk. We're trying to get people listening, talking, not being embarrassed. We need to break down taboos, which is, again, it's another opportunity for me to show you my golden vulva and purple clitoris. And also, there's a growing body of artists doing work, and some of these photographs, there's a lady in the bottom left-hand corner. She presented this at an exhibition in Manchester. It's her tapestry of a vulva. Bottom right-hand is some jewellery that was being interestingly, at the back of a stand when I went to a craft show at the Birmingham NEC. So I was a bit disappointed it was tucked away in case it upset anyone, God forbid. But actually really pleased to see it, the vulval art. And the top right-hand corners are some rather fabulous vulvas that have been crocheted by a dear friend of mine, Zoe Hodson, who you might know as the Manchester Menopause Hive. She's got a rainbow one as well, actually, but I haven't got a picture of that. And the top left-hand one just made me laugh because this was a football stadium in the Qatar Football World Cup. And either someone was being a bit cheeky and tongue-in-cheek or they didn't realise. Whichever way, I loved it. So, yes, next slide, please. Right, this is a busy slide. So genital urinary syndrome of the menopause, what a mouthful, but GUSM. The reason that the naming got changed from vaginal atrophy is that vaginal atrophy was kind of too small. It implied that it was only about a sort of, well, atrophy is not a very nice word, is it? It's a sort of a shriveling up and getting old and everything. But actually, lack of estrogen affects so much more. It affects our bladder stability. It affects all of the external tissues as well as our vaginas. So we need estrogen to keep the tissue of our vagina and our vulva, it's slightly acidic pH, and that is important because we need that pH in order that the microorganisms that live in our vagina are kept in the balance that is good for us, because they're all living in this harmony and they're dead clever and they look after us. They make our vagina self-cleaning. So think self-cleaning oven. Do not douche it. Do not use any of these feminine products that I hate to see that are pushed by big pharma. You don't need them. They upset the bugs that live in your vagina. What your vagina needs is to be left alone, and it needs some estrogen to keep it nice and healthy. Also, our bladder, the muscle there is stabilized by estrogen. So we need, without it, we can get that irritable bladder, you know, like you're getting up, I need to go for a wee all the while. Have I got cystitis? What's happening? Oh my goodness, I've put the key in the door and now I've absolutely got to go to the loo. All of these things are bladder instability. And one, again, this is taboo breaking, so I'm sorry if I cause offence, but on direct questioning, because people rarely raise this with me in a consult, during intercourse, sometimes women can experience some incontinence, either a little bit or it can be a gush and quite a lot, and that can be because all the tissue is irritable. So I don't know how big a problem that is, because it's not the sort of thing that we talk about, is it? But again, in opening the narrative and getting my models out, I'm hoping that people feel more confident to check themselves, to look at themselves and to talk about themselves. And I know that in some communities that's even more difficult than it is in mine. But again, if we can all start to increase that narrative, we will be helping health a lot. I think there are large numbers of older women in nursing homes have been treated repeatedly for urinary tract infections. And actually what they need, and the reason that they're distressed and the reason that they may be getting the urinary tract infections, is because all of this tissue has become unhealthy because of lack of estrogen. And if you see here, the little hole, at the top is the clitoral head, the purple thing. At the bottom is the vaginal opening, and there's another little hole. That is the entrance that leads up to your urethra and into your bladder. So that's really close to everything. So if it's not well estrogenized, causes big problems. So how do we look after all of this down below? I've touched on it before. Please no douching. Please no funny vaginal deodorants, hygiene products. Don't do any of that at all. You can wash with either water or with an eczema type wash, which would be something like Dermal or Cetraban. We should be moisturising our vulval area much like we moisturise our face. So we can use eczema emollients like Cetraban, like E45, like Aveeno, anything that we like to use. Or we have got specific products that are made, and there's a company called Yes, which I really like. They don't pay me. I've got leaflets and booklets here. They produce a vaginal moisturiser. It's like a gel. They also produce oil-based and water-based lubricants that can be used by anyone. They don't contain any hormonal additives at all. There are other brands available. There's Silk, there's Regel. All of those will absolutely help the tissue. We can also use hyaluronic acid, which I think there's a growing vogue for, to put on the face to try and reduce the wrinkles. Well, it does the same in vaginal tissue. It improves moisture, and there's several products out there. One that I know is called Hyalofem, and it's a gel that contains hyaluronic acid. Interestingly, it's cheaper than stuff you put on your face, so I don't know if they're interchangeable, but you can use that as well. Obviously, then we've also got vaginal estrogens, and there are a myriad of ways that we can deliver vaginal estrogens. Probably the most common way is to have a little tablet, a bit like a thrush tablet, one called Vagifem. They came in an introducer. That, again, there was an introducer with every tablet, and if you're using it 2 to 4 times a week, that's a lot of plastic going into where we don't want it. So there's another brand called Vagirux, where you get 24 tablets in a box and 2 of these that are reusable. So you pop these little tablets in at night, they dissolve overnight, and then they help. We can also get little gel pessaries. That's like a torpedo thing. You pop that in. This one's called Invagis. There's another one called Blissful Gel, and they dissolve again overnight. I'm going to show you another personal favourite here, which is a bendy vaginal estrogen ring called E-string. It is odorless and tasteless for those of you whom that might matter. And you pop it in yourself. Health practitioner will do it for you if you like. It stays in place for 3 months. You can take it out to have sex if you prefer, but it's also perfectly safe to have for sex. And then you replace it every 3 months. So that's called E-string. So that's a really good product. We have vaginal estrogen creams. There's one called Avestin. When do I use Avestin? It's a more potent concentration. So for someone that's got really resistant problems, I would use that. And also for people that have got real problems with their vulval area as well, you can use the cream outside and apply it around there much more easily than you can with the pessaries that are going to dissolve. Perhaps I have no idea how I'm doing for time, Charlie, so you might need to text me or poke me. But the other thing that we should, are we okay? Am I doing okay?
Yeah, I think it's safe to say we're running over a little bit. So what I've done is I've shared all the resources in the chat already. So for those who want the slides are in there in a slightly more translatable kind of language. So you can read through everything that we're showing on screen in there. So if you do need to go early, that's absolutely fine. But please do stick around if you can, because there's so much more for us to cover. And it's wonderful that you're going into so much detail. We really do appreciate it. There is also there's a second document there as well, which is a whole load of links to other stuff, because we're not the answer to all of your questions. There's going to be so many more life experiences to talk about, other organizations that can offer different insights and things as well. So the second document is a whole load of links to other blogs and talks and articles and things as well. So take a look at that. But we'll be here for probably, I imagine, at least another 40 minutes or so. But these questions that you're submitting in chat are absolutely brilliant, and I'm making a note of all of them, and we'll get round to them just towards the end. So please do stick around. And remember, this is being recorded as well, so you can always come back and watch it again. I will now disappear again and hand back to Jacqueline.
Okay. I just want to have a quick word that I think it's really important that we learn to examine ourselves down below. You might need a mirror for that. You can do selfies and have a look, but it's important to know what we all look like. So this is a very stylized vulva. Nobody's got a golden vulva apart from someone in a James Bond film once. So vulvas are, depending on our racial origins, that they may be pale flesh coloured, they may be mid-brown coloured or dark brown coloured. The other thing that's not uniform is this is dead neat and it's dead symmetrical, isn't it? Well, we're just not, are we? So the labia minora, which is the little inside lips, they can be one big, one small. They can be both big, they can be both small. All sorts of different things, slightly less variation with the labia majora, but we need to know what we look like. If we're without estrogen for a long time, these inner bits, the labia minora, resorb, which means they get flatter and smaller, and eventually they can completely disappear. So we need to know what that is. What we also need to be looking for is if we see any areas that might be white or thickened, we need to report that to a healthcare professional, because that might be a condition called lichen sclerosus. God, don't doctors like Latin words, honestly? But we need to monitor that, and it needs different treatment. There's another condition called lichen planus. Likewise, if we get little blisters, we need to report that, different coloured discharges. So get used to what you look like. And if there's anything you're not sure about, do report it. So the only other product that I haven't mentioned here is there's another product. The trade name for it is Intrarosa, and it's a precursor of female hormones and testosterone as well. Actually, can be used vaginally. I would use it for people who are not getting benefit from estrogen or from vaginal estrogen, or that the products they're using are causing irritation. And the other really important group it's of use for is people who are having treatment post-surgery for breast cancer, who are on one of the newer class of long-term drugs called aromatase inhibitors, which might be something called letrozole or aripiprazole. And these you can't use vaginal estrogens with these as easily as you can with tamoxifen, for example. So we would use the Intrarosa preferentially for people who are having that sort of treatment for breast cancer. Okay, next slide, please. Okay, I think I've covered this pretty much. That is basically saying very succinctly what I've taken quite a long time to say. I'd just like to say my slides didn't look like this. Charlie has made the most amazing slides for this presentation. So thank you. I'm in awe of your IT wisdom and creativity, Charlie. Thank you. Next slide, please. Right, breast cancer always crops up. So, right, where's my thing? I've got a copy here as well of what's up on your screen is a really wonderful, I think, pictorial informatic that's produced by the Women's Health Concern, which is the public branch of the British Menopause Society. And it shows us breast cancer risks. And this was produced a little time ago. So when this was produced, the background incidence of breast cancer was approximately 23 cases being diagnosed every 5 years for every 1,000 women aged between the age of 50 and 60. Now that incidence unfortunately is rising. We don't know exactly why. I think there may be something to do with a lot of the plastics and the plastic bottles with the plastic that's seeped in. So environmental factors as well as lifestyle factors. But what we know is that there are lots of things that increase breast cancer risk. So second from bottom is weight. So our weight goes up when we're perimenopausal and menopausal. That is normal. It's quite a complex reasons that happens, but it does happen. But if our BMI gets really a long way above the top level, then that is increasing our breast cancer risk. We know that exercising decreases breast cancer risk, and it is the one intervention that we can do that gives us the biggest improvement. So increasing our exercise is not only good for our cardiovascular health, for our mental health, it's also really good to minimise breast cancer risk. So the other one that's a reduction in risk is having estrogen replacement if you've had a hysterectomy. So isn't that interesting? So women are using estrogen and yet they've got a lower risk of breast cancer. It's because there's no progesterone in there. So that's good. So the other ones that increase risk, if we go 1, 2, 3, 4 up from the bottom, that's people who are drinking more than 2 bottles of wine a week, which is 2 units of alcohol per day, which is a surprisingly small amount, isn't it? 2 bottles of wine per week will increase your breast cancer risk more than even if you are using the old-fashioned HRT. I've just seen a little question about a subtotal hysterectomy. People who've had a subtotal hysterectomy may have some remaining cells from the lining of their womb around. So if that is the case, they will need to have a progesterone as well. So it's a little bit of a complicated question. So if someone's left your cervix in, it's fine if they've taken every iota of endometrial lining tissue, womb lining tissue away. But if they've left a little bit, then we have to give you a progesterone. Okay. So what we do know is that the modern micronized progesterone is a little bit safer in terms of risk. But actually, when you put the whole thing together, when I've seen a lady today, actually this morning, and she's gained weight, she stopped exercising, she feels irritable, she's not eating so well. So she was doing all sorts of different exercise classes, including pole dancing. Now she hates the way she looks and feels, so she doesn't do it. So her weight has gone like that, her exercise has gone like that. So actually, if I can get her feeling better so that she's back on the pole dancing, she's exercising again, she's getting out, she feels confident, she can get her BMI down with the HRT, her overall breast cancer risk will go down even at 5 years. So I think it's part of the whole, so we need to think about it. People who've got a very strong family history of breast cancer are obviously going to be much more concerned. Those people will probably nowadays have had genetic testing, so will know what their risk is. The data that we have is not conclusive like in so many things, but the feeling is with the data we've got at the moment is that your background risk is your background risk. It is unlikely that adding HRT into it is going to increase it further, but you're still carrying a high risk. So you need to think about that. People who have had DCIS, which is a precancerous non-malignant condition, having HRT does not increase the risk of having breast cancer. However, if you've had DCIS, a pre-malignant condition, you carry an increased risk of 30% of having a cancer in the other side. And if you do get it again in the other side, it stands a chance of coming back as estrogen positive. So then HRT will cause you a problem. So if you've got a complex family history, please speak to someone that knows their figures, knows their data, and can talk you through it so you make the decision that is right for you, which might be to use HRT and be very vigilant. It might be to choose non-hormonal options first and see if you can control symptoms and make lifestyle adjustments without, or it might be that you try those and then you decide that you still feel pants and that on the balance of benefit versus risk, you're going to try HRT, but it's your decision and it's my job to help you to make it. Next slide, please. Okay, again, I think this is a little bit about the last slide, that the feeling is at the moment, and again, we need so much more research on this, but we are feeling that HRT is not causing brand new breast cancers to arise, but it might be that if there's a very early change there, then feeding it with estrogen can accelerate the growth of that. There have been a few trials looking at breast cancer and mortality rates as well. And the other thing that we know is that people who use HRT stand no higher risk of dying from breast cancer than people that do not use HRT, which implies really that those cancers are curable. So again, it is complicated and it needs time and a good conversation and for lots of factors to be taken into account. Next slide, please. Okay, I also have a steady stream of people coming to see me who are over the age of 60 and people who have had HRT in the past, and because of what's happened in the last 20 years. So we had the publication of this big trial, the WHI study 20 years ago, and that scared lots of people off using their HRT. So they stopped using it because they thought they had to, because they were going to die of some horrible disease. And then they found that they're still having flushes and they still feel dreadful. They're looking at the new research and they're thinking, actually, I want to start it again. So we have this group of people. So what can I say to people who are more than 10 years from the last period or who are over the age of 60 when they're commencing their HRT? And really the most important figure here is more than 10 years since your last period. So The optimal time to start HRT for your long-term health benefits is during the perimenopause. We know it decreases the incidence of developing diabetes and heart disease. However, there is no evidence that starting it more than 10 years after your last period is going to cause you any problem. What we can say is that you are unlikely to get the cardiovascular benefits. You may get some benefits still if you've started to develop thinning of your bones and osteoporosis. At the very least, it can hold it at the stage that it's at. So you're not going to get quite so many of the long-term health benefits. What you are going to get is symptomatic benefits. The risk that people have worried about is an increased risk of cardiovascular disease, and that concern came out of a trial that was published a good few years ago, and now probably 15, 20 years ago. And that was conducted on people using oral synthetic HRT. And that seemed to show that if you introduced that more than 10 years, you were increasing the incidence of cardiovascular events, which would be angina, mini strokes, heart attack, strokes, all of those sorts of things. Now, the reason for that, we think, is because of the effects they had on blood clotting. So what we would do nowadays is that we would counsel that there's no benefit. There's a small risk of risks, but we think probably not. But what I would do is I would check somebody's cholesterol. I would check their blood pressure. I would calculate their risk, something called the Q risk 2 of having a cardiac event. I would modify what I could. So if they needed blood pressure treatment, I'd ask them to get it, cholesterol treatment. And then once that was done, or if they hadn't got any risk factor from that point of view, I would talk to them about starting a very small dose of estrogen through the skin. And I would be very, very gentle about how I increased it. So when I talked about Lenzetto, the spray, this is the group I might use it in if that was their preference. So I'd start at a low dose, and we'd be taking a good 6-8 weeks to go up from that very small dose. And we do it really slowly, and we'll settle on the dose that just controlled their symptoms. So yes, it is possible to have it. You need to talk to someone that knows about menopause care. You need to look at the whole of yourself, your lifestyle, your family history, your medical history, and then a decision can be taken, but it's certainly not a blanket no. Next slide, please. Utrogestan I've already covered actually, which is the progesterone that we preferentially use. Nowadays, the micronized progesterone, this is what we use. The British Menopause Society consider that we can use it vaginally, but we should try using it orally first, because that's the licensed way of doing it. But if people are having real problems, then we can use it vaginally. What is really, really important with progesterone is that I have come across some people who, perhaps because of the growth of information on social media platforms, have talked in their own chat groups and have changed the way they take their progesterone, because there's around 10% of people who are very sensitive to progesterone. So they have mood problems and bloating and other difficulties with progesterone. So they may be tempted, on the advice of well-meaning friends, to adjust their dose. I would say to you, please, please, please don't do that. You're having progesterone for a really good reason. It's to protect the lining of your womb from becoming cancerous. So if you've got a problem with your progesterone, please speak to your healthcare provider. We have strategies for dealing with sensitivities, the different products that we can use. We can help you manage it, but don't change your dose and without advice. We have quite a low threshold now for increasing to 2 of these capsules because of data that was published in the last couple of years about safety of the lining of the womb. So some of you may get advice to take 2 of these orally, or 1 orally, 1 vaginally. But my really big take home message is don't go off piste on your own. Please ask your healthcare provider. So next slide, please. Okay, which one you choose, gel or spray, it's very much personal preference. Patches are good if you're busy, you haven't got to wait for anything to dry in the day. You've just got to remember, which can be tricky, little post-it notes, you've got to remember which day you've got to change it. So they're really good. Also, patches are really good for migraine sufferers because they give the most level, stable estrogen levels, which is because migraines are hormone sensitive. And I haven't gone into migraines because I just don't have time, but migraines are hormone sensitive, so we need nice stable levels. So patches are better for that. Gels, handy, they're daily application, you can't see them, there's nothing to have, there's no adhesive that you're trying to get off if you've got a little black bit, you're not trying to cover anything in clothes. If you're in that, if you're someone that likes to wear thongs out on the beach and stuff, you might not want to have a patch on there, so gel is your friend. It's really good for starting dose is very low. It's very flexible because as long as you're only following the instructions from your healthcare provider, you can adjust and micromanage at home yourself. So that's good. And again, the spray is good if you want something that's going to dry very quickly. There are some people still who don't absorb well through the skin. And it's really interesting. There's been some work done, and people with darker natural skin tones, so people from the Asian continent or African continent, will absorb through their skin much less efficiently than someone with a pale skin will. So there's all sorts of factors when we're looking at different products. And some people just prefer to have a tablet. And if they're low risk from a cardiovascular and a thrombosis point of view, then that's certainly an option that should be explored. I get asked as well, can you split your estrogen dose? Yes, you can with an estrogel. So because it's 1 pump per area, if you're needing 4 pumps, that can be quite a lot of areas. And some people that are poor absorbers, we might occasionally go above licensed doses, in which case you're struggling to put the extra 2 on. So you can split the dose in that circumstance. You can put half on in the morning and half on in the evening. In terms of swapping estrogen products, I know with the supply issues at the moment, there's been a lot of swapping and changing. So if you can't get one patch, you're being given another one. Obviously, if there's a supply issue, we have no choice. But what I would say is that every person absorbs every product differently. So, for example, I absorb that sachet gel better than I absorb that. I absorb from Estradot patches better than I absorb from ever until I've been through the mill of products. So that's going to be the same for everybody else. So if you have to change products, don't do it unless you have to, really. If you found something you're stable, stick with that. Okay. I think that's all that slide. Should we go to the next one, Charlie? Can we have too much estrogen? Yeah, so what's important is not how much you put on your skin, but how it's absorbed through it. And there's been an awful lot of talk about this in the press recently. So there are a few people whose symptoms do not improve on the products that I've given them up to the maximum licensed dose. And for those people, I would then be doing a blood test to check and see what their levels are. Now, the blood tests are reasonably reliable for patches. They can be very problematic with the gel because of the way the gel is absorbed, so it's not as easy to do with gel. But if I found that someone was putting on 100 patch or 4 pumps of gel and they were still having hot flushes, I'll be scratching my head going, they can't possibly be absorbing, and I do a blood test. Then if I found they've absorbed a little bit, so they're absorbing some and they really want to stick with it through the skin route, then I would go up above the licensed doses, but not otherwise. So what can happen if you have too much estrogen? There's some obvious side effects. There's breast tenderness, there's headaches, there's bloating. And the truth is, we don't know what would happen if you have very high levels. So if you're coming back and you've got levels of in excess of 800, 1,000, 1,200, we don't know if it's going to cause a problem, but we don't know that it's safe either. So I think most people would feel well with an estrogen level, an estradiol level of around about anything between 2 and 500 or 600 perhaps. And that's the sort of level that, generally speaking, we feel is adequate. Obviously, there was a Professor John Studd in the 1990s published a paper saying that he was noticing that levels of up to 1,000 were needed for some people with mood problems. That is possible, but again, it's something that I wouldn't do routinely. It would be very much on an individual basis. Okay, next slide, please. Okay, periods and HRT. Again, I think I've already covered this earlier fairly much, which is probably a great relief to Charlie. So we use sequential or 2 weeks on, 2 weeks off HRT if you're still having a natural cycle, and we move to a continuous regime long term, because we know that it's safer. Okay, so this is something I haven't mentioned. How is it safer? The lining of the womb is a wonderfully clever and fantastic bunch of cells. But if it goes AWOL, we can get cancer of the lining of the womb, and rates of cancer of the lining of the womb are going up in our Western civilization. Part of the reason for that, I think, is the increase in average BMI, because again, we know that carrying around too much weight increases our risk of this sort of cancer as well. So we're very keen to be looking at that. And we know that if we give progesterone continuously, so every day, it is safer for the lining of your womb in terms of any cells going a bit rogue. So that's why we try and move you, not only because it's convenient, because like, who wants periods? I mean, some people like having periods, it works for them, but most of us, I think we can safely say we'd rather not be doing with it. The Mirena coil is a really effective method of becoming bleed free. And also, if there's concerns about the lining of your womb for any reason, the Mirena has another use I haven't mentioned before, which is that it is used for minor abnormalities of cells of the womb that are kind of precancerous, not cancerous. So we know it is super safe from that point of view. So all sorts of different regimes. Next slide, please. Okay, how do you talk about menopause with your GP? Well, I had Aline was listening to this, so it's a shame she's not here. She's much more expert than I am. But what I would say, having been a GP, is GPs are super pressured with time. It's a really hard job, and a menopause consultation I can run over on an hour with a new patient. So doing it in 10 minutes is virtually impossible. So what can you do to help? The advantage your GP has got is that they know most of your past medical history without having to question you like I would have to. And they know probably quite a lot about your family. So how you can help them is that you can track your symptoms. I would say with regard to tracking devices, be careful which one you use. Some of them, and check what the privacy notices are, because some of the data may be used in ways that you don't want, and you're sharing quite sensitive and also quite valuable data. So just check the T's and C's on your tracking app, but do track your symptoms and take it with you to your appointment. It's worth having read about the current guidelines and recommendations so that you know what the NICE guidelines are. There is a superb information booklet that has been produced by Diane Danzebrink and her team at Menopause Support. The collaborators on it are people that I know personally. So the 4 healthcare professionals that have done it, 1 nurse and 3 doctors, are all brilliant. It's a free resource. You should get it in your resource pack, the QR code to go with it. So this will be really helpful. And Diane on her website, Menopause Support's got a really good, helpful sheet on about how to approach your GP. So the more information you take, the more they are aware that you are clued up, that you know what the guidelines are, the more you are likely to be able to get the result you want. The other thing I would say is, if you're not sure who to go and see in your practice, speak to the receptionist. They'll know if there's someone with an interest in women's health or HRT. If they don't know, ask other people that are registered. They will know. If you feel that what you're asking for is within guidelines and you're meeting a blank wall, then I think you always have the option of change your GP practice, ask around and see which one is perhaps a little bit more open and clued up about all things menopause. I'm really hoping that education is improving and a lot more practices are offering a lot more comprehensive help. Also, go along to community meetings. There's the menopause cafes. There will be something in your area that is run. There's a lot out there now that's available on different websites, and also Instagram and TikTok. All of these places have got lots. Nigar Arif has written a really excellent book. Again, I think I've managed not to bring it upstairs with me, which is called The Knowledge, which again includes lots of information. So there's lots out there. Do your homework and take it with you. Next slide, please. And there we are, other resources. So I've used Menopause Support, which is the one for this booklet here. Other books that I recommend. This is actually titled The Complete Guide to Premature Ovarian Insufficiency and Early Menopause. I would say it's relevant for everybody. It's a brilliant book. It's written by Hannah Shaw and Mandy Learnhardt, and it's excellent. If you're particularly interested in brain health, I would recommend this book written by Dr. Lisa Mosconi called The XX Brain. Might rev you up a bit, talks quite a bit about the disparity for women's health as well, but it tells you the lifestyle measures to improve your cognitive reserve. It tells you dietary measures, and it talks about hormones. If you've got particular vaginal symptoms, there's another good book written by a layperson who has significant vaginal problems called Me and My Menopause or Vagina. Some bits of it are with a strong stomach, but it's a funny book and it's written with love, I think. And then for those people who choose to or feel they cannot take hormone replacement therapy, I would recommend reading this, which is The Natural Menopause by Dr. Anne Henderson. Okay, and of course, I come back to the lovely booklet. Okay.
Amazing. Right, I'm going to pop us on to this next slide. We're going to grab just a 10-minute break. What I encourage you to do, we've already had some great questions in chat, which I've been filing away, which I will fire at you in a moment. But we'll grab 10 minutes for a comfort break because I bet people are absolutely gasping for a cup of tea and a pee or whatever. So take those 10 minutes and we'll come back. Right, everyone. Thank you very much for another few questions popped in the chat. We'll just wait for Jacqueline to pop back on and we'll get those sorted for you. So I'm going to quickly whiz through some of these questions. So I think you already answered Mandy's question about the subtotal hysterectomy, so we'll move on from that one. I think what I'd actually quite like to start with as the opening headline is some of the references you've made have been to like private prescriptions and things. And while that is really, really beneficial for those who can access it, I think it would be really, really helpful to know if there's a bit of hope for most of us who can't actually have access to that level of kind of prescription service. So I know that you work with some local organisations here in Birmingham, and you know of some others where there are GPs appointments and things available. Who are those connections that you can recommend to us to have those conversations? I know there were some kind of funded places. Have you got any other recommendations of how to have those conversations in a way that don't necessarily spend £400 on a tube of treatment?
Yeah, absolutely. Well, the only product that I have mentioned today that is not available on the NHS is the Australian pink tube testosterone. And actually, even privately, I don't prescribe that. Everything else is available on an NHS prescription. They knew there is a menopause prepayment, an HRT prepayment, NHS prescription charge now. And what you do is you pay one prescription fee per item for your whole year's supply. So if you're on the patches, you only pay that £9, whatever it is, 65 once. But not every product is available on there. So testosterone is not available on that, but vaginal estrogens, the Utrogestan, the patches, the gel, the spray are all available on that. So you shouldn't need to have to access any private care. I had been involved in a program with someone locally where we'd got some lottery funding to offer 2 menopause consultations and prescription charges to people on low income. But I think it's, for a variety of reasons, that is going to be very difficult to continue. So that's not going to be available anymore. So I'm now sort of moving to try and help to facilitate people to gain their prescriptions from their NHS GPs. The difficulty we have now is because the NHS is in such a terrible state, our wonderful NHS that's under siege. Menopause clinics are not considered to be essential services, I don't think, and they built up a huge waiting list during COVID, so we're now looking at about a year. So which is why what I'm trying to do is to empower people to be able to communicate well with their GPs. But every product I've mentioned, bar this one, is available on the NHS, and I don't use this. It's not worth my money. I think it's perfectly fine to use the other stuff.
Brilliant, that's really helpful, thank you. So we had a question about the relationship between co-occurrence between GUSM and issues with reoccurrent thrush and BV as well. So is there a relationship between those two? Would that be an indicator, or what do you feel the relationship would be there?
Okay, this is really important, actually, the whole question of thrush, and I'm building up to one of my Instagram things on this. So people who no longer have estrogen do not get thrush. thrush does not grow in postmenopausal people. So, which is why if you go to a pharmacist and you say, I've got thrush, I want some treatment, and they say, how old are you? And you say, I'm 52. They'll say, well, no, you need to go and see your doctor or a practice nurse about it. Because of the way everything changes, we don't get thrush. So if you've got itchiness and dryness and you think, oh gosh, I must have thrush, it's itching, go and get yourself looked at or look yourself. It's much more likely to be low estrogen. Again, BV, these are things that you get bacterial vaginosis because there's been a change in the natural, the gut, the bugs that live in the vaginal tissue. So normally we need something called lactobacillus, and that looks after everything very well. If we start douching or we've got some other environmental changes, we knock that off. It doesn't stick around. It's not very good at clinging onto the walls. And then we allow other bugs to overgrow, like one called Gardnerella, which causes BV, which is that grayish, smelly, fishy, blech, horrible discharge. So they're not really to do with low estrogen. They're things that would more typically happen to you before you hit the menopause. One condition that I have seen in a couple of ladies that got a lot worse, people who have got the herpes virus genitally, and lots of us have it around our lips, cold sore virus, but we get very upset if we've got it genitally. Again, we can manage it like we do cold sores, but if you've got very dry, irritated, vaginally atrophic, lacking in estrogen tissue, again, you might get a resurgence of your herpes. So it's all interrelated with vaginal health. Does that kind of answer the question?
I think so. We might get a response in the chat if that's answered it or not. There's also a question about a relationship between HRT patches and vitamin deficiencies, because they recently started a combo patch, went back to the GP due to feeling very tired and weak, and had a blood test and deficient in vitamin D, and now on high dose vitamin D. Do you think there's a relationship between HRT patches and vitamin deficiencies, or is that an unrelated thing?
I think they're unrelated things. I think that virtually everybody that lives in Northern Europe is vitamin D deficient because we don't get enough sunshine, particularly this summer. And when we're out in the sun, we use sunblock. So we're, particularly in the winter, the recommendation is that absolutely everybody takes vitamin D. And it's particularly important for people who have a darker natural skin tone. So people who are not they're ethnically not from Northern Europe, they definitely need to take vitamin D. And this is why as well, I think GP is actually really well placed to do menopause care, because there are this huge 35 recognized symptoms that go with the menopause and probably growing every week, but they can be caused by other things. So it's my job to try and work out what is caused by your hormones, what might be caused by something else. So if someone's got sort of borderline celiac disease, so they're not absorbing their B12, they've got an anemia because of that. That doesn't mean to say they haven't got menopausal symptoms as well, but what it does mean is that only treating their menopause is not going to treat the whole of the thing. We need to look at both. And so the answer to mending everything isn't just to have ever more HRT and more elaborate routines. It's to look at the person as a whole and see what else we need to adjust that might mean vitamin D, B12, folic acid, whatever.
Absolutely. It's definitely about the whole person. Two quick questions, because I think absolutely everything else that came up in the chat has been answered in the rest of the presentation. So two last ones. One is about the risk of oral estrogen. Does that carry over to other purposes that it's used for example, when it's used in gender alignment?
Yes, absolutely. Whatever the purpose that you are using it for. So I mean, the experience that I've had with a transgender woman was that we used patches. So she had estradiol patches. It doesn't matter whether you were born male or female, oral estrogen, it goes through your liver, whether it's a male, whatever, it's going to cause increased thrombosis risk. So yes, absolutely, same for transgender. Okay. And same for the combined oral contraceptive pill as well, actually.
So that's definitely a conversation to be had with your medical professional about what's happening, for if that's something you're going to be on for a while, definitely have that conversation.
It is, and it might be appropriate to have the tablet, Charlie, if that's the right choice for you, but it needs to be an informed choice.
Yeah. All these things, isn't it? I think that's generally the gist, isn't it? It's about the informed decision and having that information and this kind of knowledge. And Absolutely. The final one was about PCOS, and is when with that being a condition, you know, that impacts all of these, your body in so many different ways, is the menopause as a different experience? Are there different things to look out for in the ways that your body changes in, you know, in peri or actually during menopause itself? And what are there different flags to be considering with conditions like PCOS?
Yeah, I think whether you've got PCOS or not, you are still at some point going to run out of eggs and go through a menopause. But the difference in your experience may be that if you have PCOS, you've probably had a lifetime of irregular periods. So that's not going to be a red flag for you, because you've probably gone for months without a period anyway, and then you've had spotting and all sorts of things. So that absolutely doesn't make a difference. We know that having PCOS increases your risk of having insulin resistance, metabolic syndrome, and type 2 diabetes. So all of those things, which is why one of the treatments is a diabetes drug called metformin. So because we also know that a low estrogen state makes us less good at producing insulin and managing our glucose, obviously you've got a PCOS person, they're at high risk of diabetes anyway, if you add in low estrogen. So I think they're a good argument to be looking at leveling out hormone levels, because you want to optimize everything. So perhaps not the answer you were expecting, but yeah.
No, it's a really interesting one. Thank you. I think that's everything that had come in the chat, but I'm sure people will probably email us. And I know that you'd said that things that come in after this, we can potentially throw your way and see what comes back. But what I will do is I'll just quickly move to this last screen that shows Jacqueline's amazing organization, Lotus Menopause Care, which is all her dazzling fine self, where you can contact her for a chat in her clinic. And then there's us, the Active Wellbeing Society, and the Virtual Wellbeing Program, where there's lots of activities and things. You can join us online for anything from, you know, yoga, breathwork classes, nice chilled out place to do on a Tuesday afternoon, to cardio combat on a Saturday morning if you really feel like getting that cardio. And there's so much to do that's all about this whole person approach to how you do your menopause journey or any other health journey you might be on in your life at the moment. Thank you everyone so much for joining us today. Thank you so much, Jacqueline, for everything that you have put into all of this. This has been so much energy and so much that you've given us to help people with this really just, it's precious information, which I know that we say go to your GP with as much information as possible, but honestly, when it's so difficult to get your hands on the information, having it concisely said by somebody who really does know factually what's right and wrong, what's, you know, where to bust the myths and that kind of stuff, it's really, really valuable. So thank you so much.
That's a great
and yeah,
pleasure.
no, it's been wonderful. And yeah, so check out the resources. If you're watching now, you can pick them up in chat. If not, they're going to be on the website very, very soon. So if you're watching on YouTube, you can pick them up on there. And make sure you keep digging, make sure you find out other people who are like you, who've had experiences like you, what else to expect in the world, and look out for other experiences that aren't like yours as well. That's what we try to reflect in these resources, are other people that you can learn from as well. So maybe if you just wonder what the non-binary experience of menopause might be like, or if you're wondering, you know, what it's like for the South Asian community to begin conversations about menopause, have a look at those articles as well, because that can be really useful, even if it's not necessarily your journey. Learn from their journey as well. So I encourage you to read all of it, not just the bits that are yours. So yeah, thank you so much, everyone. This has been fantastic. And even if we did run over by a bit, but well done for you know, just sticking with us. And I don't know how much tea you've drunk, but I've drank quite a lot. So have a fantastic afternoon, everyone, and take care. Have a great day.